Sometimes you see a kid, for some reason, that gets little tiny dots in the face after vomiting, but nowhere else in the body. Is that a blood disease or not a blood disease?
That actually is something that can happen to anybody. The increased blood pressure that occurs during an episode of vomiting, especially in the upper part of the body, and the changes in the pressure in the blood vessels allow for a very small amount of blood to actually be lost under the skin. And that phenomenon, which yields these little purple spots, which are called petechiae, it's a benign event. And does not mean that the patient has a blood disorder or that he has, for instance, an infectious process.
But sometimes you see it spread throughout the body, and they go to the doctor, and he says, well, we got to take some blood tests. They found the platelets are extremely low, like under 10,000. And he says, well, it could be a blood disease, and sends it to you. What's that all about?
Well, that's actually a relatively common phenomenon in childhood and also in adolescence, although the process is probably different in the two. The entity, the disease you're talking about, is something called, for brief, ITP, and the long name of it, because in medicine we always have long names, is either idiopathic or immune thrombocytopenia. And it's a long name with big words, which essentially means that when we say idiopathic, it means we don't know where it comes from. If we say immune, it means that it's related to a malfunction of the immune system. And this is the most likely reason for this, as I'll explain in a little bit longer. Thrombocytopenia just means low platelets, and purpura means the bruising and the petechiae, the little purple dots that are associated with this illness. It's actually a frightening condition because all of a sudden a kid that is generally healthy is covered by bruising and petechiae, and the first thought that goes through the mind of generally the physician who first sees this and the family is that this patient has a dreadful, potentially a malignant disease. The vast majority of these patients actually have a relatively benign condition, and although the platelets are involved intimately in the process of clotting and the ability to stop a bleed, the likelihood of a severe bleed, of a bleed that occurs that will leave sequelae, and what we're always concerned about is the possibility of a bleed in the brain, it's actually extremely unlikely.
Well, you know, I studied that, I think it was at University of Michigan, Children's Hospital, and they couldn't find any major CNS bleeding from it.
Yeah, indeed. One of the gentlemen who has spent his life studying this condition, Jim Buzel, has currently what we call the registry, because it is such a rare event that we really don't understand it. And developing a registry that is piling up a number of cases will help us understand better this phenomenon. In my too long career at this point, I actually only have seen one of these events, and at that time actually the patient was...
Well, your career's actually gone through a couple of centuries now, right?
Kind of. But the important thing also is that there is really no significant correlation between the number of platelets and the bleeding event.
But so, we still like to get the platelet count.
Well, it actually, it's an interest. This is ITP is one of those areas where there has been all kinds of controversies within the hematology oncology community, and there are some people who will advocate not to treat. And the reason for that is because the risk of bleeding seems to be exceedingly low, and the fact that the vast majority of these kids will recover over time.
But if you decided to treat, what would be the treatment if you decided you should treat this?
Well, I will come to that in a second. to complete the previous question,
Okay.
I think that there is a right middle in the sense that, first of all, there is an agreement that if a kid has a bleeding event, say nosebleeds, gum bleeds, things of that sort, and the platelet count is 10,000 or 5,000 or 12,000, that is very low. That kid should be treated. Nobody, a bleeding event could eventually, in the long run, create a threat to that kid, and so it's reasonable to treat. We use 10,000 as an arbitrary number for treatment. Generally, above 10,000, the symptoms, or even the bruising, tend to be minimal. Below 10,000 tends to be a lot more obvious. And part of what one wants to achieve by treating these patients is to have a relatively prompt recovery of the platelets so that the tremendous anxiety that is generated by this, and the fact that one has to impose restrictions on the patient, and the fact that the patients may bump their head and then develop a problem, it's significant. So we generally, if the patient is 10,000 or below, or if they are bleeding, we treat. And the way we treat this condition essentially is by tricking the immune system that is now being too active. This is a disease where the immune system, the good Lord gave it to us so that we can fight the outside environment that is threatening to us, makes a mistake, and therefore attacks the platelets. So the platelets here are consumed, are destroyed fast by the immune system, and the organ where that destruction takes place is the spleen. So what we do is we either give very large amount of immunoglobulins, and that takes the spleen, gets busy with that and forgets about the platelets, or we actually make a trade. We put an antibody that binds to the red cells, and then the red cells become destroyed, but there are a lot more red cells than there are platelets. So the spleen gets busy with the red cells and the platelets go up. One concept, the other possibility is to use steroids. A lot of us tend to leave steroids at this point as the last of the resources in patients who do not respond to the other two treatment. One is so-called IVIG, the other one is called Coulmbia.
Well, if the platelets are low, why don't you just give them platelet transfusion?
Well, it's because the platelets will be destroyed. Although in some circumstances where there is a dramatic situation with severe bleedings, then at that point we use everything we have, including platelet transfusion, in the hope that the platelets, the few platelets who manage to survive long enough will help the bleeding. But the reality of life is that this is a disease where the lifespan of the platelets is shortly reduced, and because of that, platelets will be given from the outside will have the same fate, meaning they'll die, they'll be destroyed very quickly.
The reason it happens is probably some antibody created by a virus or something?
Well, if you look at the history of the typical kid that has ITP, there is generally a viral illness that precedes this by a couple of weeks, which is essentially the period of time it takes for antibodies against any infections to be formed. So the general concept associated with ITP is that during that immune response, there is a group of B cells, the one that make the antibodies, that essentially makes a mistake. So the antibodies that is formed also binds to the platelets, and so the platelets are considered by the body as a non-self, and therefore they get destroyed. Now, one of the things that happens is that any immune response sort of goes up and then goes down, meaning that the amount of antibodies tend to go away, and some of them go away more rapidly and some of them go away less rapidly. So the general concept is that ITP always gets better, but for some patients who may have a much stronger clone, much stronger immune system, it may take years, and those are the ones who become chronic. The vast